It's working. Yeah.
Got audio. Rachel, can we get started? Good. Okay. Good morning, everyone. Good morning. Thank you, everyone, for attending today, both in person and online. Echo. Is there something running? Apologies for the technical issues. We won't have any video streaming of the speaker, but at least hopefully everyone can hear us. It's my privilege and honor today to welcome Dr. Jean-Pierre Farmer. He'll be speaking to us today about selective dorsal rhizotomy from pathophysiology to longitudinal functional outcomes. Before I go into his biography, which unfortunately won't be able to cover all of it because it probably takes too much time, I do have to provide a land acknowledgement. Ottawa is built on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. I've known Dr. Farmer for a number of years, and I've had the fortune now to personally thank him for coming today, as well as offering his guidance and mentorship in helping us start a selective dorsal rhizotomy program. This is something that was the baby of Dr. McCormick, who I think all of you guys know. And it's taken us a long time to get here, but we wouldn't be able to do this without Dr. Farmer. In brief, Dr. Farmer started his practice at McGill in 1990, where he still holds an active clinical practice, but over the last 16 years has moved into leadership roles. There's a lot to cover, but he is the leader on many levels. Some of his greatest achievements were creating the Department of Pediatric Surgery, where he served as the inaugural chief and foundational chair. He's recruited 32 new professors and seen to the promotion of 17 more. He's won innumerable awards. He's published over 180 peer-reviewed publications. He's received awards for both his interdisciplinary care, his leadership, as well as receiving awards for the best manuscript of the year in neurosurgery, which is one of our most prestigious journals. He's played a key role in bringing multiple technologies to Montreal Children's Hospitals, including intraoperative MRI scan, Dr. Buchanan, as well as a ROSA robot to Montreal Children's. Please, I hope everyone can welcome Dr. Farmer, and we look forward to your talk.
Well, thank you very much. It's a pleasure to be here. I hope that people online can hear as well. We'll try to be relatively brief, but there's a lot to cover. But with the time and all this, I'll try to see. Some of the videos speak for themselves, but we have to let them run. We can't condense them. So I have no disclosures. The objectives of this talk is to cover a bit of the pathophysiology of spasticity, cover also patient selection for rhizotomies, and give you a brief overview of long-term functional outcomes. Spasticity has many etiologies, as you can imagine, but cerebral palsy stands out because it happens in the developing central nervous system, and it is also incomplete, leading to the typical pictures that we see, whereas these other etiologies may not have the same manifestations of spasticity. CP is a collection of non-progressive childhood neurological syndromes resulting from an injury to the immature brain, as I mentioned, characterized by abnormalities of posture and movement. And the movement disorder that we're most interested in treating is spasticity, but often the clinical picture is mixed. This is an old slide, but at that time shows that usually approximately 55 to 60% of patients have an element of spasticity dyskinesia and ataxia was less, and hemiplegia, which is not a condition for selective dorsal rhizotomies, was significant as well. I do have more newer slides, but I'm showing this old slide as well in terms of the tendency. So total incidence was 5 per 1,000 in 1979, but there's a big association with low birth weight, especially the immature kind of baby with low birth weight, and also with just small for gestational age. In 2023, this paper came out more recently that the incidence is down to 2.5% per thousand, 2.5 per thousand, but the relationship to low birth weight and prematurity continues. The presentation is often mixed, as I mentioned, but there's a spasticity component that is potentially targetable in 82% of cases. Rhizotomy candidates will be those children where spasticity prevails and where the other movement disorders are not overwhelming. What's the pathogenesis of spastic diplegia? So if we talk about the premature population, they will have a chance of being exposed to hypotension, hypoxia, ischemia, because they have vulnerable immature glial cells and limited watershed vascular end zones, as well as poor autoregulation. They then develop astrocytic gliosis, focal necrosis, multicystic cavities, which ultimately end up, by the time we see them, with some white matter atrophy and secondary ventriculomegaly, not necessarily hydrocephalus. Typical picture here, this is from one of Park's articles that shows the white matter in black in this sequence of MRI. So attenuation of the periventricular white matter is the hallmark of periventricular leukomalacia and spastic diplegia. Often the pictures are a bit different because although there is PVL here, there are other diseases that coexist, like intraventricular hemorrhage or prematurity, that can lead to injuries elsewhere, like in the caudate, leading to dystonia in some of the patients. So we start with the injury, ischemic periventricular leukomalacia. There's a loss of suprasegmental modulation of the reflex arc, and there's a loss of suprasegmental facilitatory influence on distal fine limb movements. And there is a synaptic substitution that takes place with a lot of 1A, 1B, and 2 afferents coming in, and these are coming from the extrafusal muscle fibers. And this leads to a lack of coordination between agonists and antagonists. If we remember the homunculus of Penfield, if the injury is small, such as in spastic diplegia, then leg fibers will be affected more than hand or facial fibers. And as a result, we get the clinical correlate of this is spastic diplegia. At the segmental level, there is less, you see my pointer, I guess, yeah. There is less inhibition by descending fiber tracts because of the white matter injury. And as a result, there's an upregulation of afferents coming from the neuromuscular spindle, and also a disorganization of the interneuronal pool. So the gamma loop becomes an important substrate for the spasticity. So we have spastic diplegia. Spastic means that it's velocity-dependent increased tone, and the diplegia means that it involves the legs more than the arms. If you go with this pathophysiology, then you would expect when you see patients a history of prematurity. That's a red flag if there's no prematurity. Hypoxic ischemic encephalopathy in the history, onset in infancy, and non-progressive disease. That doesn't mean that the spasticity doesn't progress as the child gets longer, bones get longer and all this, because the tone is increased, but the underlying disease does not progress in cerebral palsy. And that's important if we're going to do an operation to modulate the tone for a lifetime, I think. Neurologically, they have motor delays, hypertonia, hyperreflexia, clonus, and weakness. And orthopedically, they'll have contractures, subluxations, possibly at the hip, scissoring, and toe pattern of gait. So initially, they will have low tone, head lag, ATNR, primitive reflexes, difficulty sitting, difficulty with the lateral threat to protect themselves from falling, eventually start to walk, usually with assistive devices in the better GMFCS categories, and then have a scissoring and toe pattern of gait. So our evaluation team is composed of all the health care professionals mentioned here. I'd say that there are more than one physiotherapist, obviously more than one occupational therapist. There are two orthopedists, one neurologist, Dr. Poulain, and myself in neurosurgery, now Dr. Catani also starting to get involved in this program. So when you multiply it, it's a big team here shown during COVID with all our masks, but it's this interaction between orthopedics and neurology and neurosurgery is very important in patient selection, as well as the assessment the physiotherapists and the occupational therapists make. So we have to identify diseases that are not really amenable to selective dorsal rhizotomy. Here, look at the patient's left arm and left hand. This is how Chantal Poulain brought the dystonia in this patient. This one has more, so he has difficulty walking, but his main problem is generalized dystonia. And you'll see that it's a mixed pattern when he starts to run a bit. He will fall over, and then you have a bit of scissoring like this. But his predominant problem is dystonia, so it's not a patient amenable to rhizotomy. We also look at the MRI. In this case, which is not a patient from our clinic, but some related to medication, where the patient lost caudate nucleus bilaterally post-injury. So we have to look at that. I showed a scan also that had some injury. And this patient has chorea a little bit, very young baby, and you'll see how she uses her right hand to hide the chorea movement that she has, a choreiform movement that she has on the left. And this patient is a patient who has atetosis, very mild and limited to the left upper extremity. Is a patient who had hemispherectomy for epilepsy. This patient was referred to our clinic, but his problem is generalized chorioatetosis. The reason he's not able to sit or walk is not because of the spasticity, but because of the atetosis, so not a candidate. And this patient came late to our clinic to see if we could help him. He's already walking. He's got 2 sticks there, but his pattern of gait is not scissoring and toe pattern of gait as much. The problem is when he gets rid of his canes, he has no balance. So this is not a patient for selective dorsal rhizotomy. But there are. I'll show them a bit later. One other thing that's important for us to distinguish is what's spasticity versus what's rigidity. And these are the hallmarks of spasticity, that it's unidirectional increased resistance to passive movements. Anti-gravity muscles are more involved. The tone is increased, is velocity dependent, which is not the case with rigidity, and the reflexes are hyperactive with clonus, which is not the case with rigidity. So with all I've said, I think you could imagine that some of the good prognostic factors would be a child who has predominant spastic diplegia, history of prematurity, young age. We like to operate on between 3 and 7. It's a question of plasticity of the central nervous system. No spinal or joint deformity of significance, no prior orthopedic surgery, adequate cognitive and motivational abilities for compliance and a supportive family. On physical exam, we would find that their child is purely spastic, no, not much or very or none, dyskinesia, ataxia, or rigidity. Spasticity limits the function. There is absence of profound weakness, and the best test to do that is a graded response, a repeated squat to stand exercise, because if they're able, you cannot use spasticity to do the squat to stand. You have to use your underlying strength to do that. Some forward locomotion and adequate trunk balance. Absolute and relative contraindications would be, or poor prognostic signs would be global dystonia, as I mentioned, severe damage to basal ganglia, severe fixed joint deformities or scoliosis, several previous orthopedic procedures. We have done some children with hydrocephalus. It can happen that they, intraventricular hemorrhage and PVL coexist in the same population, so some of them have had shunts, and that's not been an absolute contraindication. Some have had CNS infection, trauma, in early childhood in particular, severe head injury can lead to spasticity. We think children do better than adults, but not in the very young. I'm talking about car seat kind of injuries. Older children, we've done some to 8 or 9 because they arrived in Canada at that time, not because we waited for that time, and severe cognitive delays. So the role of the operation is to downplay the 1A, 1B, and 2 fiber afferents from the neuromuscular extrafusal fibers. And the rhizotomy is done intradurally at that level, so that there is a better balance between what the brain tells the legs to do and what the reflexes do. So we have to have a balance at that level. And that's why we have to be selective and not cut too many roots to abandon spasticity, but not have enough adequate strength to continue. The surgery itself is, we use a total IV anesthesia because we need neuromuscular responses. So propofol with a TCI pump and sufentanil at this rate, sometimes 0.2, 0.25, 0.3. Propofol, the rate can be adjusted with these pumps, but you're trying to create a steady state for the entire stimulation period. I've done the operation this way. I learned it in New York from Rick Abbott, and I've always done it this way: a narrow laminotomy to expose the entire cauda equina. The advantages are that we can be sure of which level we're at by looking at the foramine and by counting the roots from below up to make sure that we incorporate S2, which is a root that also goes to the bladder, and we can have room to divide the roots into sensory and motor with this fashion. In this fashion, the laminotomy is narrow, so we've published that the rate of spinal deformity is very, very low, and is probably not higher than if they had not been operated, really. And I think there are some that do the operation at the conus. I guess the key thing for me was that usually they don't include S2, which is important at the ankle level and at the toe level. And they can't be sure if it's really L4 when they're stimulating and all this. So I try to be very cautious with L4 and with S2. This is dividing into sensory. And we apply a 1 millisecond square pulse to obtain a threshold at all levels. Those that came to Montreal saw it. The entire dorsal root is stimulated at 2 to 4 times the highest threshold intensity in a 1 second 50 hertz strain, and persistently abnormal roots are divided into rootlets and then stimulated and lesioned. This is our OR setup. So we like communication. I have these transparent drapes. I can see what the anesthetist is doing we have our screens. The electrophysiology team can see what we're doing. The physiotherapist is under the drapes as well to palpate the contractions. And this is a bit of a closer up for this. Dr. Poulain looking at the camera here. So we follow the Phillips and Park classification in terms of motor responses. So, but we only cut really roots and rootlets that are grade 4 responses. So a grade 1 response would be stimulating right S2, for example, getting a gastroc contraction. Grade 1 response, it's a more sustained contraction than is what is expected. The first half of the screen is the stimulus, and then the other half is after discharges, if you want. Right S2 here, this is a grade 2 response because there's an adjacent two muscles that are being activated. Grade 3 response would be all muscles ipsilaterally, but no crossover and no spread to the upper extremity, the last one, the last line being deltoid. And a grade 4 response, which is what we're looking for, is this kind of response where there is crossover and perhaps a bit of upper extremity spread. We've analyzed this data with this paper, which showed that there was in 93% of times, there was consistency between EMG and physiotherapists and between trial 1 and trial 2. When we were stimulating the entire roots, we had I think 3,000 data points. It's a paper that was accepted without revisions. So it's showing that if the first time you stimulate, you get a grade 4 response, you're good. If you get a grade 3 response, there's a chance that it could move up to a grade 4 and become a root to cut, but you'll never get a grade 2 response to move to a grade 4. So that is helpful in guiding the electrophysiology. And this is showing our roots that when the lesioning rate for rootlets that have a grade 4, roots that have a grade 4 response is closer to 80%, but for overall lesioning rate, which is to maintain that balance between elimination of spasticity, preservation of function, the roots assigned the overall lesioning rate is about 45-46%. So again, this balance that we want to preserve, this is for the therapy that follows at the Shriners for 6 weeks. So in the therapy, the goals are to stretch the tight joints, strengthen the muscle groups, and gait retraining. They have 6 weeks of intensive. It can be 4 weeks if the patient is doing relatively well of intensive rehab, focused on muscle re-education and strengthening and all this. Thereafter, it's continued outpatient 3 hours per week for physio for the first year and 1 hour of OT per week. The results when we started this procedure, there were no outcome measures, if you want really, other than the Ashworth scale, which is known to everybody. So we showed very early that the spasticity score drops and remains gone for life, if you want, 15-year follow-up in here. We had the goniometer to look at range of motion angles, and we saw an improvement which is durable, at least the first 5 years in this study. But then came GMFM 88 scores and eventually GMFM 66 scores, which are 88 items, in this case 5 dimensions, including standing and walking, but also crawling, sitting, and lying. And the other outcome measure became the GMFCS classification, which has level 1 as being an independent ambulator, level 2 with holding onto the ramp, and so on. This level 2 thing is a bit tricky because it's age dependent. You can be a grade 2 and still use a walker until you're 5 or 6 years old, and so that's a bit something to take into consideration in our results at the end. So with this, looking at GMFM for our groups, stratified by GMFC grouping, we found total GMFM score. This is after 15 years of follow-up to improve and stay elevated for these dimension D, which is standing, and E, which is walking, also improvements. The same thing if we do it, but there are improvements in other dimensions like lying down and so on and so forth that you think are, the surgery is targeting the legs, but they are showing improvement. And finally, if we stratify this by GMFCS stratification, the goals that you set up for your GMFCS 1 or 2 patient is different than the goal for your GMFCS4 patient. They don't achieve the same result, but in relation to themselves, they actually do quite well. We also looked at activities of daily living with the PD score, which I don't need to go into details. I think it's a proven reliability tool. And we found that self-care and mobility improved significantly in both groups, and again that the improvements have to be stratified by GMFCS category, this one for mobility and this one for self-care. During a 15-year follow-up period, there can be other interventions that happen to patients. They don't, and so I think it's important to take this into account. And so we looked at this for our group because we didn't think we had as many adjunctive procedures done as other groups were reporting. And so in this 88 patients that had a follow-up of at least 10 years, we found that about 60% of the time, children only had SDR, and another 12% or 12.5%, so that's a total of 72, just had the Botox alone. So 28% needed to have orthopedic surgeries, and about half our bony procedures could be femoral antiversion procedures, or and another portion of that group only had soft tissue, and some had both. So our orthopedist, Dr. Benaroche, tends to be, and Dr. Quentin tend to be quite conservative. We let them go until they're older to decide about other procedures. And I put this slide because there was one patient who was a twin, grade 4, GMFCS grade 4, not a twin, a triplet, and both parents were physicians and all this, but who eventually needed spine correction, but her twins that were not involved also developed scoliosis, so I'm not sure how much this has to do with the natural history of a GMFCS4 patient and the genetics of a triplet. So we showed you patients who were not candidates. Here's a patient that is a candidate. His name is Ali, and he's probably 35 years old now. But he was 3 then. He just arrived from Israel, I think, and he has a typical spastic diplegic gait. He's using a forward walker, and this is him in the first 6 weeks post-op. So he has like a drop foot or not much dorsiflexion yet. And his mother has kept his ponytail because she wants him to have more strength, a bit like Samson in the Bible, I think. But this is him. He's using a K-walker, which is already an improvement for his posture. Now he has the haircut because he's at 6 months post-op. He still has AFOs. He's a shaky walker, but he's definitely walking much better than he was. And you always have to think that we can't roll the clock back and see them how they would have been without the procedure at the same age, if you want. This is him 10 years out, so much old, quite good, and he's got some active dorsiflexion there, and he's walking well. And when he runs, maybe there's a little bit of interning of the foot, but when he's barefoot, but he's never needed any other procedure. This little boy, that's what happens often, is purely spastic diplegic. A little guy from Alberta, I think. And what he does is he uses his upper body. He's not really using his legs much to walk. So he's walking with a walker, but he's cheating, I think. And this is the same person, but 10 years later. And this is pretty difficult to detect, to have him stand out in a crowd, I think, as being different, I think. So good active dorsiflexion, you can see maybe slightly better on the right. This patient, we talked about generalized dystonia. This is a patient of Dr. Poulain, actually, and she referred her to the clinic because she has dystonia on the right side, the right arm. You see that she's not holding on to the pommel as well. But she had a lot of spasticity, and this is her walking better. You'll see as she ages that the dystonia doesn't respond, and the right arm is getting worse and worse. But her gait has been good. This patient was already a GMFCS1, but clearly a bouncing type of spastic diplegic gait, no issue, but already walking without anything. And this is him 15 years post-surgery, coming to visit us, driving his car, going to university. This patient, Zachary, we hesitated because he's kind of cute. He's walking with a bouncing gait. So we saw him a few times because some people said on the team he's too good. But when he came the third time, I think after 6 or 8 months intervals, she said, I want to ride the BMX like my brothers. They were all into BMX. So he had the surgery and he's riding his BMX, but this is inside the house. Because it was at Christmas, so the father sent me, the father, 18 months after the surgery, sent me this video. So that's him powering his bike, and he doesn't look very much like so for him, the goal was to do like his brothers, and I think in that sense, we were able to do that for him. So now we get a bit more into the more scientific follow-up, not just videos before and after and all this, but there wasn't much in terms of randomized controlled trials on the study of this condition, except the short randomized trial in the late 80s, Seattle, Toronto, and Vancouver, looking at Ashworth scale only, and showing that physiotherapy alone left still some spasticity. I think a follow-up was 6 months only, whereas rhizotomy plus SDR led to a reduction in spasticity. Dr. Steinbach and the group here, Dr. McLaughlin and all this, retrofitted the data from the 80s when the GMF 66 change came up and showed, there was a improvement in GMFM, but it wasn't, it was barely significant, but this was not a very long follow-up, if you want. So in our 2020 study, the one that got the Paper of the Year award, we compared the motor function following SDR to the expected natural history of CP patients up to age 12. How did we do that? We kind of used the data from McMaster University that looked at the spastic diplegic patients in the 90s and early 2000s that had access to physio, OT, and also access to orthopedic surgery, but no access to rhizotomies. And these patients were not either treated with rhizotomies or baclofen pump. And the patients that we had were stratified by the GMFCS functional status, as I've done in all the publications. The GMFM66 scale was used because that's the one that shows the biggest change to a procedure, after a procedure. And the control group was generated from that normative reference. All children that had on the SDR for spastic CP greater than 1 year follow-up, there are many that had 15-year follow-up, documented GMFCM, FM66 on pre-op and post-op. There were 245 patients eligible. Some we didn't have pre-op GMFM because of what I said. The tool came out much after we started doing the procedure. Some didn't have post-op data. Some children we know were not CP, but we ended up with 190 patients. They all had it's GMFM 66. Some data that was GMFM 88 was transformed into GMFM 66. There's a conversion device to be able to do that. And it has still 5 dimensions, but a few less items. 180 eligible patients. The GMFCS levels that were most operated were 2 and 3, as would be expected. A bit of good-looking GMFCS4, and a small number of poor-looking GMFCS1 that were almost GMFCS2. And this is the study period and the age at surgery. The average age is this. So the biggest group, GMFCS3, those that are using walkers or assistive device. You get data points here. The blue data points are the case control, and the green data points are our cases. So it looks like a scatter of points, but you then establish trends with this mixed model analysis of variance, and you produce curves that are in blue the control group from Hamilton, in red the patients that had the surgery. And we saw the biggest improvement in GMFM 66 in the GMFCS3 group. And the age range at which we operated was this, the mean this, and it didn't influence the outcome of the patients. When you analyze these data, you have to have what's called a minimally clinically important difference of 1.3 to be sure that your procedure is doing something. And with the overall group, this is what we get to. So overall group quite improved over the MCID, and this is after 10 years. But by category, we had to regroup 1 and 2 together because we didn't have much of category 1 patients. Usually we say they're too good for surgery. And this is what we come with. So the biggest delta in GMFM 66 comes from the group that are using walkers, but all groups improve over their MCID significantly over years. Another way of expressing it would be their percentile curves change in GMFCS 2, 3, and 4 as a result of this. The group from Hamilton showed that for GMFCS 1 and 2, there was a stability model that worked for them because they're projecting them. They measured them until age 12, but they're projecting them till age 21. But that for 3, 4, and 5, because of the effect of growth on the spasticity, like these are patients who did not get surgery, that there is a decline at adolescence, or which starts at around 8 years of age. So to study our patients, we had data up until 21 in some patients, but in 48% of patients we had more data after age 12. But we used the mathematical modeling that they used to see what best fits. And because the adolescent decline is of a significantly smaller magnitude in our entire cohort, our match was much better with a stable limit model, whereas they used for categories 3, 4, and 5, they used the peak and decline model as the best fit for their population, the so-called natural history patients. So this is showing this. If we start with the group 3, this would be, the green curves. I think they're green, yeah. Are the patients that the green curves. I'll use this one, the group 1, because they separate more easily. The green would be the typical grade group 1 for the natural history study. So their results show this trajectory in terms of their improvement. Our patients, if are starting worse in the category 1, because we don't take very highly functioning kids, and their natural history would be that red line. It's parallel to the blue line, but the blue line parallel to the green line, sorry. But the blue line is what they've actually done. So they're crossing over. In group 3, we have about the same GMFCS level or GMFM level to start between the control group and our patients. The results then of the patients that are operated are superior, even in grade 4. So in grade 4, you'd say, why do you do rhizotomy? So we're including their patients who are not quite grade 3, are grade 4, but they are better starting than those that are grade 4 in the natural history, and we show that they improve over their natural history. The problem was with group 2 because they didn't look like the curves match, and that's related to the fact that GMFCS2 category is age dependent, that you can use a walker at age 4 and still be considered a grade 2. And I think, it means that the physiotherapist predicted that they would get rid of their walker. If they didn't, then they didn't improve as much. So when we said, well, was this before age 4 or after age 4? Then the two lines separated beautifully for that group 2. So I think that was just related to the GMFCS category. I'm going to end quickly, I think, with this NNT, which we established for rhizotomies for our group at 1.73. When you compare with the literature, aspirin for non-fatal stroke versus major bleeding event, Lipitor, all this, the NNT is much higher than 1.73. The thing that comes close to it is temporal lobe epilepsy surgery, published from the group in London, Ontario, where the NNT is closer to rhizotomy. So it is the largest single institution cohort in terms of longevity of follow-up and all this. Longest analyzable follow-up. Control group has a control group. It's a natural history cohort. The effect size is in line with the randomized control trials, and the data beyond adolescence is present in 90 patients for us. And the procedure has been always the same throughout these years. Limitations, it remains a retrospective study. There's a bias for patient selection, rootlet selection. Control group is based on a natural history cohort from Ontario, and the mathematical modeling after age 12 for both is being used to compare both groups. But we think that the SDR provides statistically significant long-term benefits on motor function if the patients are appropriately selected. The benefit is clinically significant for all groups. The biggest benefit is in the group of children using assistive devices. And improperly selected, the patient's NNT is quite low. I have a bias on this slide. I think that stimulation plays a big role in the selection of the rootlets to cut, and that if you do it without the selection, you might, if you cut just on the basis of clinical outcome or clinical manifestations, you may be quite wrong. We're publishing a paper now showing that in asymmetric patients, we still lesion pretty much symmetrically. And we think the reason for that, some of them had an asymmetric MRIs, others had a symmetrical MRI. But we think the factor in this that causes the clinical asymmetry is the dystonia, which is not treated by rhizotomy. So, and paper of the year in the luncheon seminar. And this is the patient that was, coming from the university, driving his car and all this at the end. What our future directions now is our CP group seem to have smaller bones and defects in bone trabeculations. What is the impact of rhizotomy on bone morphology, given the better postoperative axial loading? So we're looking at this, obviously, with our collaboration with the Shriners. And do asymmetric patients have asymmetric lesioning at surgery? The short answer, we'll wait till it's published, but is no. And the reasons are explained. And what about SDR in non-CP patients? So we have a group of maybe 400 patients total, but a group of 25 to 30 that had the familial spastic paraparesis or other syndromes. And we're comparing how they did with how the CP patients are doing to help us. So that concludes my talk. I hope I have time for questions, a few questions. Dr. McCollum?
Yeah. Dr. Farmer, first, thank you so much for your presentation, and it's truly an honor to have you here. I love the fact that you started with the patients that you wouldn't choose, because I think the choice is really important. Like, to have the outcomes, you have to choose the right patient. One of the things I worry about over the long term is the weakness component. So we do them between 3 and 7 or 4 and 8, depending on where you live or where you send them. But I saw your long-term outcome data. It doesn't seem that, maybe it's not as big a deal as I worry about. I mean, they do get the Trendelenburg and the, that's part of the CP, and the weakness is definitely a part of having cerebral palsy. But do you worry when you're assessing them when they're little that they're going to have all of this growth and gain weight and worry about the weakness component?
Sorry, Dr. Farmer, do you mind just repeating the question?
Oh, sorry. Do you want me to come closer?
No. It's just that they might not be able to hear it all.
So the question was from Dr. McCormick was, are we worried that the patients will get weakness in the long term, especially when they gain weight and all this? So we had these concerns at the beginning as well, and Rick Abbott had these concerns when I was in NYU as well. But I think the key is not to eliminate too many roots and to stick to the grade 4 responses. And I think if you do around 45 to 50% lesioning rate, that's amply sufficient. You've seen that spasticity is eliminated. but you preserve some underlying tone and strength, I think, with that approach. We also, I told Albert when he came, we were cautious with L4 because it's stability at the knee. We never take more than 25%. I'll take the worst one. If they're all bad, I might go to 5 rootlets on that one and take 2 out of 5, but I will never take more. Whereas we can take 60% on S1 and the other route that we have to be careful of is S2. But we've shown with the urodynamic study before and after in the 90s that if you don't cut more than 50% overall of S2 rootlets, usually there's 4 on each side or 3 on each side, something like this. So you would cut 3 out of 6 or 4 out of 8 if they were abnormal only, the worst ones, that the patient's bladder capacity improves. They were unsuspectedly having small bladder capacity and high bladder pressures pre-op, and post-op they have normal capacity bladder, minimally normal, like at the 3rd percentile, and they have much lower bladder pressures, which presumably has an incidence on their kidney function long-term as adults and all that. So I think you have to be cautious not to overdo it. I think the initial studies from Toronto and Vancouver, looking at Ashworth scales, showed that they were lesioning, I think, much higher than this, maybe a bit like we were lesioning in New York, like sometimes cut 2 entire roots, then save 50% of the 3rd one, and then go back and cut. So I think you eliminate the spasticity just as well with 45% of the worst responding roots. And you saw it in the OR. Occasionally we're leaving one behind but it's kind of a bit of spread, but nothing like the other rootlets, and we section conservatively, I think. Dr. McMillan.
Thank you very much, Dr. Farmer. My question for you is familial or hereditary spastic paraparesis patients that you alluded to in your last slide. I know the analysis is ongoing, but can you share with us your impression of whether it looks as impressive as the patients with CP?
So we're trying to. So they have a progressive disease, unlike CP, which is static encephalopathy. And we're trying to always identify the subtype genetically. So often it takes longer to decide. And if they have most of the time the families will say, no, there's nobody else in my family who has this, who developed it at age 50 or whatever. Nobody, an uncle, nobody. It's like, but if it's a subtype that we think is likely to be very slow in evolution, then we can offer rhizotomy. They don't walk the same way. Eventually when I present those, I can show the difference. But their outcomes are quite similar. That's what the GMFM improvements are quite similar, with the exception of a couple of cases where probably we should not have operated because they went on to progress much faster than we thought. And for them, the families were still happy, but if you do this operation and 2 years out, they start to decline. You're not as happy, I think, about that. So, and some of them have cerebral disease, some of them have spinal disease, and we're trying to see which group does better. But it's a smaller group also. It's only about 25 patients or something like this.
Same age? You do?
Same age, yeah. I forgot to repeat Dr. McMillan's question, but it was about familial spastic paraparesis. Stay tuned.
Are there any questions online? Maybe not. Dr. Farmer, thank you so much. That was an amazing presentation.
Thank you.